This is Sutures and Sense. Ryan Pistone is our editor, brains, smart guy, IT, again, everything that's done well, Ryan's behind it. And we talk business to clinical and clinical to business. And tonight, I'm interviewing a friend of mine who I met back several months ago named Melissa Rice. Now, Melissa is smart, funny, was an administrator at a very busy ambulatory surgery center in Illinois for orthopedics and spine. And she has started to post a relatively regularly scheduled post called Daily Struggles as an Ambulatory Surgery Center Administrator. It's funny, it's smart, it's readable, and I learned stuff. Like, for instance, she talks about everything from a high schooler wanting to come in and watch a procedure to a new HR manual being thrown on her desk so that somebody could get hired, a family friend of someone, a surgeon demanding implants without knowing the price, or if it's, oh my gosh, even FDA cleared or approved. That seems important to a fellow like me. And she gives great, funny, sometimes frightening insights into what it's like to run an ambulatory surgery center in 2024 and in the future, and how things are changing. And I think if you're a rep or a surgeon, I think you'll find her to be interesting, entertaining, and smart. I hope. I know she's a little shy, but I think she's going to be great. Let's welcome Melissa Rice. You were telling me, Melissa, the story of the rep. Well, let me back up. You write this great series. You've written 10 to 12 to 15 of them, which is the Daily Struggle. I want to make sure the title right. Daily Struggles as an ASC Administrator.
Yep.
And I've told everybody in the intro, follow you if you're a rep or a surgeon, because they're hilarious and they're frightening, but they're funny and insightful and interesting. So tell me the one that you can talk about, because I know there's some you're not going to talk about.
Yeah.
That was sort of the craziest of the ones you've at least posted about.
I would say in the past 5 years, the wildest one that has happened to us is Monday morning. Everyone's hustling and bustling and getting, the first cases are getting ready to go, and the back doorbell rings and materials management answers it and has no idea who this person is. And they say they're here for Dr. X. Their case is at 9:00 and they're holding 12 trays that are quote unquote sterile because they're wrapped. And, they call the clinical coordinator, who reaches out to the scheduler, who then reaches out to me. We've never heard of this company before. We have no idea anything about what the instrumentation or the implants or anything about. So, we had to have a long conversation with the rep. I had to put scrubs on and have a conversation with the doctor and let them know that, there's a process and a policy in regards to bringing any type of instrumentation and implants into the center. We need to make sure that these companies are vetted. And what I mean by that is who backs you, whether it's the instrument side of it. Are you from a reputable company that, our instruments aren't going to break halfway through the procedure in the patient? Are you an implant company that has been vetted by the FDA? Are you allowed to be in the USA? There are a lot of great implants out there that are only European approved. Then we have to go through the whole process of liability, risk analysis, all that type of stuff. And then the part that nobody wants to hear, we have to go through the finances.
Yeah.
We have to make sure that it makes sense for us to use these types of things. So unfortunately, I had, to break two hearts that day, which one was the rep and one was the surgeon. The patient was able to have a successful surgery with implants that were originally asked for. And, it was a teaching moment for many people involved within the center, this new company, as well as the surgeons and, all the higher beings above.
Yeah, I know some people outside the business would think, what do you mean? It's hard to believe. Like, first of all, why would a rep show up with sterile, air quotes, sterile? We think instruments, implants, whatever it is, and nobody else knew. But that's what's so interesting about your posts. When you post about these, there's a bunch of people who run ASCs who come and go, oh yeah, happens to me all the time. And you sort of, I think we talked a little bit beforehand. We kind of understand where some of that comes from.
Mhm.
It doesn't excuse it. It actually is, but we understand why somebody who might be new might actually think that. But that's not an excuse. And I mean, that's just it's funny to think of it. And the surgeon didn't think of it either. Um,
No, and my heart goes out to the reps. I start with that, and I say, as administrators and clinical directors or directors of nursing, we truly do not care as long as it's a good product and it's going to have a good outcome from our patients. What the
right.
doctors use, what makes us feel bad for the reps when they show up is, they all went and played a round of golf together or had a really great meeting at a conference somewhere, and these reps or these companies are showing them all these great things, and I'm sure they're great from a clinical standpoint. That's just not my forte, but they are told, hey, just
Yeah,
show up.
I'll take care of it.
No,
It's
yes, then the
the
good old boy,
famous.
I'll take care of it. Well, they know they're going to be in the operating room, and I have to take care of it, and I got to be
Yeah,
the bad guy.
yeah. Well, that's yes. I've had a couple of doctors opening up. They've opened a new surgery center or new hospital, and they've got a standard case back in the day. And the guy's like, "Oh yeah, yeah. We listen. Everything's set up. We got everything we need." I'm like, "Hey, we're doing an anterior cervical." I'm like, "Hey, any chance like do they have Caspar pins and a Caspar distractor, which is like has to be. I mean, the way he did his cases because I done. And he's like, good question. Like it was 5 days before it. They didn't. Like we would have gotten in there and said, so
We
I
can't do
found one and got it right. But like
that.
it was one of those things where he had a million things he's thinking about. The ASC had never done a case with him. They kind of didn't really know exactly what they thought, what they might need. And I was the one who's like, and you go there and I'm like, is there anything else I didn't think of that we're going to find out? Right. Um,
What?
but,
I think
but
that's another good perspective for reps, especially, that's a good way to point things out because that happens to us all the time. If you know that these doctors have not done this procedure in this type of facility, reach out. You're the
yeah,
ones that intimately work with them. You can make or break the case in regards to how smoothly it's going to go. I know that
yeah.
every center that I have ran or I have consulted on, I'm always say, reach out to the reps, ask for that
Hmm,
information. Preference cards only go so far, and Lord knows they probably haven't been touched in 10 years either. So
yeah,
you're going
yeah.
to get the glove size, and that's about as good as it's going to get for
Wow.
you. So
Yeah.
reach out to those reps, get comfortable with the PAs. They know. They know the
Hmm,
weird yellow vessel loops. It can't be red. It's got to be yellow. You want to know those things. So I always tell reps, if you know and you have these great relationships, which we love, reach out to us too because we know that it's going to be great for both of us at the end of the day, and the patient's going to leave happy as well, and that's a really good teaching moment for reps too.
huh.
But yeah, reach out to us. We love
Yeah.
that.
Well, yes, but like not all reps. I actually think most reps would do it. A lot of them don't think to do it, or they think they're just going to be ignored. And I
Right.
actually think it's the exact. And I always taught reps that worked for me. So if they ignore you, who cares, right?
Mhm.
Like, but if they don't, aren't you glad you called? And
Yeah, and then because let's be real, you guys get blamed for everything in the room.
yeah,
The
yeah,
rep didn't have it, the rep didn't bring it. It's the rep's fault. I couldn't tell you how many, whether it would be in cardiac or in total joints, if something went wrong, they'd be like, "Oh, you didn't bring it," and they're like, and the rep's like, "What do you
yeah,
mean I didn't
yeah.
bring it? I don't work here,"
Yeah, right.
type of stuff.
That's my fault. That won't happen again. I don't even know what we're
You're the
talking
easy
about.
you're the easy target in the room is what I always call it. So it's like, if it's gonna go well for everybody if everything's in the room. So as long as you reached out and you could say, "Hey, I reached out. Here's my email, text, voicemail, whatever you say," then it turns back around. But
Yep. Yep.
good way to,
So,
you know,
all right. So,
around.
talk to me. Teach me something here, right? So, let's say I'm a rep, and
Okay.
a surgeon says, "Hey, I like your whatever,
Mhm.
but you got to get it approved, or you got to bring it to the ASC." And Melissa runs a place, and there's a bunch of stuff she's got to get from you before I can use it, right? And I think that's pretty common how most of these things go when you have
Mhm.
a good relationship, surgeon, administrator,
Yeah.
and the ownership. So let's say, how does that go? Like, what is it? I come in with a company, let's say you haven't heard of,
Mhm.
right? And you may know me, you may not. So let's assume you don't know me, and one of your surgeons who operate at your place says, "Let's talk to Mark. I want to use this thing for blank, whatever it is."
Mhm.
When I come in 2 weeks, 3 weeks beforehand, or whatever, what is it that you want? And then could you tell me, like briefly, kind of why? Why do you want those things? Why do you
Absolutely.
need them? Right?
So from the rep side, if they're telling you, hey, you got to talk to someone, ask for their information right away.
Mm-hmm.
Can you give me that person's information? It'd be quicker if you get a cell phone number or an email address.
Yep.
Two, if they're saying, if the doctor's coming, giving it to us, we'll reach out right away because we don't want to delay stuff. The sooner we get product in or the approval, the quicker it's off and it's on the schedule. We don't do it. One, we want to make sure that it's a company that is what we say vetted for. Everyone's going to hear vetted. What does that mean? Who are you? Who are you? Are you blacklisted somewhere, but you're trying to get our stuff in? I mean, we did use a couple implants and we found out that they were having huge, lawsuits. I'm not going to name the name of it. It's a podiatry implant. That's all I'll say, and that's why we're constantly looking at these smaller companies. Now, if you're a new rep in a specialty area, whether it could be sports med or, hand or foot and ankle, that type of stuff. And we know who the company is, let's say, and I'm not saying these by anything of favoritism by any means, but a Smith & Nephew, a Zimmer, and Arthrex, Biomet, those people that have been there around for years that have, sound names that, push out really great products. Maybe not all of them are successful, but we know who they are. We know that they're FDA approved. We know that they have resources that have reimbursement specialists that can help you if it's something new. Come to the table, one, with all of the information about the product, the how-tos. Is there any white pages about it that we need to know about that we have to present to our medical executive committee? Why we have to do that is that there are going to be doctors on the board that are going to review this information so they understand what's being brought into the center from a risk analysis and from a liability standpoint. Your medical director is going to be part of it. They want to know what's being brought into the center. Everything's about risk and liability. We want to make sure that what we're bringing to the center is not going to turn around and, bite us. In the background. We'll get our clinical, teams on, whether it be specialists from the operating room or any of the nurse, educators. Get on the website, start talking to people. We're going to ask if you're a new center, who's using it. Give me some names, give me some phone numbers. The doctor's going to talk about it. Great. Give me some surgeons' names. Let me talk to another, surgery center. My business office gets involved. I want them to know what's coming in, how much this product is. Is there a CPT code or a a HCPT code that we are going to be able to, bill out and get separately reimbursed for? Get education. Is there, some people have like these great webinars out there for some of their products. So there's a whole long process to it. It's just not showing up and giving us, your information. Then we want to make sure that, the reps have appropriate training to be in the operating room. And I know that sounds crazy when they're like, well, I'm a rep. Well, great. You're a rep. How many times have you been in the operating room? Do you know what, sterile technique is? Do you know to stay away from anything blue? Those types of things,
So how do you check that? Just out of curiosity. How do you
90%
clearance?
Well, a lot of people use RepTrex and Telecentrics. I know there's another one out there. It's a smaller company. I can't remember. I haven't used it in a while. So these corporations, let's just say Arthrex. Use Arthrex as an example. They, from what I understand and what reps have told me, and you know this because you're the rep guy, that they do this internal training. So they go through what bloodborne pathogens are, how to do HIPAA, make sure that you aren't taking anything home with you or accidentally throwing it in the garbage, all those types of things. So what happens is they go through these trainings and they're going to have certifications. So we sign up with these outside third-party credentialing companies, which are for reps that you guys have to pay for. And then we're able to tap into that and be like, hey, here it is. And it's actually, Medicare requires that. And so does each state's Department of Health, as well as accreditation. We are required. Yes, you are required.
Okay. So that means like I need to be, if I came into your ASC, I need to prove that I've been trained on bloodborne pathogens, right? Which it's funny. Most of us have by either our company internally, if we have that training, if we're big enough, or we've taken courses offered by those
like HealthStream or something like that,
or whomever, right? So that I can say, I've gone through the training, I understand all of it, but I didn't know that like Medicare. Of course they do, but I never thought about it this way.
You don't because it's not part of your everyday. It's part of our everyday. So anyone that's Yeah, so anyone that suits up and is in a clinical area that's going to be in a, have any type of interaction with the patient, whether they're awake or they're asleep, and you're a vital part of the clinical team, yes, you have to be credentialed, whether you're a
Yeah.
staff member, you're a provider, or you're a representative.
Yeah. Okay. When you start talking about vendor clearance, there's a bunch of reps that get really upset because they have to pay for it. I get
Yeah.
it, whatever. I mean, I paid for it too.
Mhm.
They can complain about how much it costs. That's a reasonable complaint. But I don't like when they complain about the rationale behind needing it. And you just gave probably the best one I've heard, which is it's pretty much like a CMS requirement in Department of Health
Mhm.
for you to
As
be in
well
these
as any
places.
accrediting body, whether it be Joint Commission,
Yeah.
which are all the hospitals, or
Mm.
AAA is what is the biggest one for most surgery centers. Yes, it
Yeah.
is a
Right.
requirement, and they look
Right.
for it. They look
Do they?
for it.
So they come in and say, "Show me your logs. Show me
Well,
who it
I mean,
is."
here, you're gonna go to, like, in Ortho, Illinois. I'll just use them since I live in Illinois.
Perfect.
They know
Yeah.
you are going to have implants as an orthopedic group. You're not just doing just knee scopes. So they
Right.
know that you're gonna have representatives in there and that you don't employ them, so that they're gonna ask you, "Where's your representative information?" So a lot of us are able to then log into IntelliSectrix, or it's called Greenway, I think.
Yeah. There's
And
there's a but
log
there's like
in,
5 different ones. Yeah.
yeah,
Yeah.
and you can show, "Hey, Mark Copeland, he was at Ortho, Illinois. He was here on 9:30. He checked in at blah, 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 blah." And it's all green check mark because you're
And
able
he's
to set,
all checked
yeah,
off.
you're
Huh.
good for it. Yeah. Because you guys got to keep that stuff up. They'll let you know, like, hey, your flu shot's coming. And they'll
Yeah.
put red check marks, and you can't check in if I say that is required for my center for you to have that.
Yeah. Oh,
So,
oh, I've been there. Yeah, yeah. It's
yeah.
so it's funny though. You just closed the loop. From I didn't know we were going to talk about this. This is
Yeah,
I
that's
guess
all
it's
right.
hilarious. This
Yeah.
is why I wanted you on because I
Yeah.
knew you'd tell me all this stuff that we all kind of know, but for you to say, "Hey, they pulled a log. Like they want to see this and they want to see," and and that's important. And so, and that is not something I expected that we were going to be talking about. So
Yeah.
can I jump? But it's cool. This is why I loved. I
Yeah.
couldn't wait to get you on. So talk to me about you talked about the due diligence a good bit. So can I wrap that up?
Sure.
Put a bow on that. It seems like
Yeah.
that's sort of checking the mod website to make sure
Mhm.
there's no issues. Um,
Mhm.
you were talking about blacklist, which is like I kind of guess OIG, right? Is that
Yeah.
OIG?
Yeah, it's
Yeah,
OIG, just letting them know that there are no crazy lawsuits out there, like as a mass lawsuit type of stuff, which is what we found out
right.
about one of our implants that we had.
Yeah,
Um,
yeah,
and kind of just looking at that, and if it's so new, and majority of the time, the medical executive will ask, "Who else uses this? What are their
yeah.
thoughts on it? How is their
That's
success
interesting.
rate?" And type of stuff. So, especially for if you know that this product's going to come and it's going to be used for a large amount, we want to make sure that we're providing our patients with the best, stuff. And again, this isn't from a clinical aspect, because a lot of the time, whoever's on the medical executive, we like it to be from the other specialties as well, so they understand what's coming into the center, especially if
That's
they're key
interesting.
stakeholders as well. Yeah.
Yeah, that's really interesting. So, okay, so let's say now, thank you. And the OIG, I think, is Office of the Inspector General, basically, right?
Yes, it is. Yep.
I
Mhm.
believe I there. So okay, so I clear
Yep.
the Office of the Inspector General. I've given you a list of other people or places that are using it. You sort of reference checked me.
Yeah.
Um, my company is on the up and up. My product
Yep.
line is on the up and up. We're just not very well known.
Mhm.
And you come in, I bring it in. We do everything the appropriate way you've described, and then we get to the financials. And
Yes.
this is one of my favorite parts. I'm actually fascinated by this. So
Okay.
you and I have talked offline about people coming in with products that are more expensive than potentially the reimbursement you're getting from the private payer or even CMS or private payer for the patient. It's sort of like all over the place. So
Yep.
tell me how you do that. If I come in with something, you're familiar with the procedure,
Mhm.
maybe you've used somebody else for like one of the big companies you named.
Yep.
And now I'm coming in and the surgeon's like, hey, instead of using them, I want to use Marks. We
Yep.
get through that process. What do you want for me that makes it easy for you to run the finances, to run the economics? And how do you look at that?
We
Explain
just
that a
need the
little bit to me.
raw cost of everything. No
Okay.
potentially this, potentially that. Just tell me how much this is going to cost for this case. Is there potential to talk if this is going to be in the future something that's going to be brought in? Like looking at construct pricing and that type of stuff. Is it something that all the other doctors are going to start using? If it's not, what we do is I truly appreciate companies who have reimbursement specialists that are going to assist you in regards to if it's new or you're going to use a new HCPCS code. But what representatives need to understand is that the financials that are given from their side over to us is just the raw data of what Medicare is going to say that you could potentially make off this.
Right.
Every surgery center has its own specific contracted rate per each payer outside of Medicare.
I remember talking to you about this, and
Yes.
this can be incredibly confusing to people
Yes.
in your position, right? Much less you have multiple contracts with
Yes.
multiple payers.
Yes.
Different. Some of them are different types of payer. Like,
correct.
So I come in and I have the information, or my company has the information that says, "Hey, here's the CPT codes," or that's probably what you would be looking at for a reimbursement, right?
Mhm.
But you have to run that through. I know hospitals call it sort of revenue integrity, right? To look at, hey, our payer mix, if we plug this in, what would it look like? Because what those specialists give, and they're great, are CMS based, and we know that's just one part of the payer mix.
Correct.
So when you get that and you say we're now doing an ankle fracture, right, or whatever, for argument's sakes, and the construct is going to be blank, but we want to look at all our payers to see if we did these ankle replacements with all these different payers, what would it look like? Is that basically in essence what you're trying to figure out?
There's two sides to it. If it's a scheduled case, we already know everything. So I could already know what payer it is. We could blankly look at it. In ASCs, they have ASC specific software. And all three of them that are out there, the big ones, all three of them that are out there, once you're already scheduled, you load your contracts into the system. So it automatically pulls it based off your particular contract. Or this is where it gets very confusing. And even 90% of the surgeons that are a part of it, they're like, what? So you can load it. I'll just leave it very granular. You load it in there. Once you load all your CPT codes based off how you're going to schedule your procedure, it'll do an estimate of what your potential reimbursement rate should be. It could be within seconds that I can know for that particular patient. Now, if we're talking from a large spectrum of like, hey, I want to start bringing this in because all of the sports medicine docs are going to start using this. Sure, I'm going to say, give me what you got. Give me a week. Let me sit down with my RCM team, my director of revenue management, whatever you call them, business office managers. Let's look at every single payer. Let's look to see what works the best. Now, I've done this with total joints. And I've turned around, and I'm talking about all of them, from the top to the bottom, everyone that, because all the doctors use all different ones. And I say, listen, we all know what Medicare pays. It's out there. You could just go out there and look at it. You're going to get a little under 10 grand for a total hip. And like, I want to say it's like a little under 9 for a total knee. Okay. So you already know what it is. But you don't know what my fixed costs are. Is it it doesn't matter to you? No, because you want to sell it, you want to go. But we have to consider that, to make sure it makes sense. So what typically will happen is I'll come back to you and say, hey, we got to be in this ballpark, because I want to make sure that I make some type of revenue as well, because then the doctors want to make revenue because then they want a part of their distribution.
Yeah.
What can happen if it's something that's going to continue to come in here is a lot of people are going to ask for tiered pricing. I'm going to ask you for just give me your standard pricing that you're going to give. Let's discuss Medicare. And I have been humbled by some that are absolutely like, no. So, well, then we can't use your product. So that's fine. I get that you don't have the margin to, fix it up, but it does not make sense for us. They're going to have to take it to the hospital. 9 times out of 10, that's going to get back to the doctor. There's going to be a golf game or maybe a steak dinner with some martinis, and then they're going to talk to me differently in a week. So I appreciate that. Or they'll say, hey, let's do this. Let's do 2 tiers. Let's do your commercial and your work comp payer tiers, and then let's do a Medicare tier, and they ask for us to be, honest, and they need to know who it is when they're coming in, which is on 99% of the paperwork you're going to get anyways. And it's great because then we're in a really good team now together, understanding what it is. We can't give exact dollar amounts of what our reimbursements have, but I'm really good about giving a range of where it needs to be, and I'm not overly zealous or greedy about it because we'll lose in the end anyways, because 9 times out of 10 say no.
Right. Right.
So
Well,
there's like
that's
two different types of things that'll happen in regards to that. It's like, you're quick, this one case, I can let you know, or I got to go in and kind of look at where we're at for all of the payers across the board and
yeah.
what makes
Well,
financial
that's
sense.
it's interesting. You were describing two different scenarios where one is, hey, the case is scheduled and it's easy, but
And
like
it's next week type of thing. Yeah.
right. And then there's the other is that's a week. And that's how I
Mhm,
would say like that's fast compared
mhm.
to what most people are used to in hospitals. But it's because it's a smaller organization. There's speed. It's it's just a faster moving. There's less people that have to make decisions and sign off and check off, and it
Correct.
totally. But
Yeah.
if we came in and if I said, "Hey, look, here's my price. Here's what I anticipate he or she is going to be using for this procedure," so you'd be looking at something like this,
Mhm,
short of generally speaking, because we haven't scheduled a case,
mhm.
but we can at least use those and saying like, he might need to do this or she might need to tweak that, so it could be 3,200 or it could be 2,900. It depends, but it's going to be within this range, and that's how the conversation starts. It seems
Yep.
like,
So
right?
normally like something like a fracture case, I'll say, "Hey, give me worst case, best case scenario. Start me out at your 3-hole plate and then take me to your 7-hole plate. Give me all of those numbers so I know where you're at."
If
And this way
if
I have them all.
so I'm your rep. You've
Mhm.
trained me. We've worked together. I've worked in your place, and I come out with this. I would be walking in with going, "Hey, I know what you like. You like the worst case and the best case. Here
Yeah.
they are." Right? Like that makes it easier. Doesn't mean I get approved, but
Mhm.
it makes your job easier to make a decision. Right?
Correct, and
Is-
you're gonna get a decision probably within 15 minutes. It's not gonna be this long, drawn out process unless we're
right?
gonna work on some type of contracting or, construct with some kitting and a rebate, then that's a little bit different. Then there's a little bit more,
Yeah.
moving parts to that, but that's a longer process. But if you're looking
This
at
is
something that you're gonna need to bring within the next week, you'll know within 30 minutes, as long as you
this
give us
is Melissa.
information.
This is so helpful. I'm telling you, you have no idea how much you're demystifying this for a lot of people. I'm telling you, like this is so helpful. So this is one more you brought up that I hadn't anticipated, but you were describing different roles people have in the
Mhm.
ASC, and
Yes.
you described a medical director, you described a
Yep.
director of nursing,
Mhm.
administrator. I forget what executive, what
Uh,
clinical.
well, like a business office manager or clinical or
Yeah,
uh director of revenue management. I mean, there's so many titles that they give,
uh,
those roles, but yes.
right.
Yeah,
Well,
so those are
let's
typically the
talk
4.
role.
Yeah. So those are
Yeah.
typically your 4 core executives that make decisions, whether it's, lengthy decisions or on the fly. Those are the
Okay.
4 of us.
So
We're in tune with each other all day, every day.
give me those four. Rattle them
Yeah.
off because I think we got them, but I want to make sure we label them when I'm
So
not
it's gonna
yapping
start
over
it's gonna
you.
start with the medical director because they're gonna help us make decisions based off, clinical stuff that we can't, make for. Then it's gonna be your administrator. Then it's
Hmm.
gonna be your director of nursing, clinical director. Then it's gonna be your business office manager, director of revenue services, whatever you call them. So those are the 4
Yeah.
key players that touch all different elements of, the surgery.
And the four of them all agree, hey, whatever it is, this thing looks logical, feasible, makes sense for us.
Yep.
Then does it go to the board? Or at that point, do you guys generally, I know generally speaking,
So typically
it,
what'll happen if it's
yeah,
something like new, we'll bring it up to the medical executive. Like most of the time it's like in an informal type of thing. It's like, hey guys, hey Dr. Cope, like, and hey Dr. Rice, like, this is what they want to use. Here's the facts, here's the data, here's the finances, here's where we think we're stand. I'll list it all out and I'm a bullet point kind of person. Like I don't like
yeah,
gray area. Like here are the facts. Let me know your thoughts if you have any questions. If not, we're gonna, move forward this because we think it's a great, whatever, blah, blah, blah. If they have any questions, they normally will just show up at our office and be like, hey, who is this? What is this type of thing? Or if they
yeah.
know something about it, like, hey, I heard about this too, because they're in the same specialty type of stuff. So it's pretty good. If it's someone new that like all the doctors want to use, we'll wait till it's a formal meeting, make it a line item, make it be a part of the, of the meeting
The
minutes.
agenda,
And then,
right.
for most places, we all meet within the same week or the same day. Then at the board, we'll just let them know, like, hey, we brought a new, service line on or a new, partnership with a new, vendor, and it's really great. Here's what they're gonna do. They're gonna bring us a broad line of, trauma stuff. We just leave it at that. So they know, most of the time legal's already gone through like their business agreement and their NDAs and stuff, which are very standard and stuff. And they know what's going on. So we know who we're bringing in from a risk and analysis and a liability.
Yeah.
I
I
think I've seen once in my career someone be like, absolutely not.
yeah. See, I, I know it's obvious to you. You just rattled that off pretty
Mhm.
easily. But I'm telling you, like I've had people say to me, "Hey, so wait a minute, what's the director of nursing and what's the administrator? Like, what's the difference? What do they do?" And they're not like it's because so many of these cases are migrating to ASCs now that
Mhm.
weren't being done in ASCs 5,
Correct.
8 years ago. That there's a lot of people who are just trying to learn this, you know,
Yeah,
and
it's a great question. I get that asked a lot, especially going to
do you?
conferences or speaking and stuff. Yeah. So, like, explain to us the difference. I said, here's the best way to put it. Administrators are the no person. That's what I've come to learn in my 15 years of my career. We're the ones that look at everything and we're like doom and gloom and we're like, no, this is the bad things about. The clinical person is going to be the person, the director of nursing is the one who you're going to really deal with in the back. They're going to make sure you know your P's and your Q's, that you know where to stand, you know where to put your paperwork in, whether it's faxing, emailing, or whatever type of stuff.
Mhm.
But from a higher perspective, the administrator has their thumb on every single thing within the ASC itself, whether it be from the pens all the way through claim processing. We have our
Yeah.
thumb on everything, but we're really in charge of like the executive stuff, making sure that things are done per protocols and our accreditation. The director of nursing has, I would say, majority of them are anywhere between 30 to 40% in a management role. The rest, they're back there with their hands dirty and really helping out back there and making sure the day goes great, which is a blessing to everyone else because they know what's going on from
Yeah.
all the different levels, but they're back there, burning and churning everything. And
Yep.
then, your business office people, they know those cases inside and out from an insurance aspect, like down to the penny.
Hmm.
They know what we're going to bring in and stuff. So they're a great asset. I could look at something and I'd be like, okay, you tell me if you think this is good because, some of these blues, they have like, these smaller little itty bitty accounts. They know those details. I don't. I know the higher level stuff that I need to know about, but they know the details. And that's why they're so important in their team as well, because they stare at it all day long. And then the medical director is the medical director. He makes sure that no one hurts nobody. And if they do, he fills out the paperwork. He's
See,
drinking coffee all day long, walking around because it's normally an anesthesiologist. So
exactly, exactly. Oh, I could listen. I could talk and have a drink with you all day
yeah,
long. I love this. Um,
yeah.
anything. I think it's funny. uh, From calling on ambulatory
Mm,
surgery centers for about 10 years, 12 years now. When in doubt, I just went to the administrator and said, "Okay, what am I supposed to do?
same.
Hi, I'm Mark. What should I be doing here?"
And I tell
And
people, don't have humility. Just walk on and be like, I'm new. Tell me
yeah,
what I need to do. I said the
yeah,
best thing, I will say, Arthrex, I'll never forget, they had like a huge turn of like people like kind of moving on into higher level parts of their stuff. So they had a bunch of new stuff. And literally, the district manager walked in, he goes, they are the bosses. They will tell you when to speak and when to go to the bathroom. I'm like, don't make that. We're not that bad. He's like, ask questions. If you don't know when to cough, ask, can I cough? Like, I'd rather you ask than assume and then you're, in trouble or type of stuff. So, get to know your clinical team. The more personable you are, the better it's going to be for everyone involved.
yep, yep, yep. Well, listen, this has been great. I hope to have you on again because
Yeah.
you explain so many things in a language like that we can all understand. And I as I get older, I
Mhm.
realize how important that is. And
Mhm.
you speak on a level to the audience, and the audience doesn't always know all these
Yeah.
things, and you just explained all of it. So I really appreciate that. Um,
Thanks.
I'm going to have you back on, and then
All right.
I'm gonna probably have you at some point tell us um, what's the perfect way to do this for a rep to come in and say, how do we do this?
Yeah.
Walk me through this, and what's the perfect value, like vac pack, or that's what some of them call them, but like so that
Yep.
you can do your due diligence, finances, and business assessment the
Absolutely.
easiest. It's still a lot of work,
It
but I
is.
think like companies could make it easier, and some are good at it. And that's I'd love to
Yeah.
know who like
Yeah.
think of the best ones and why are they good. That's going to be the next time I bother you.
All right. I
I'm
will
going to
leave you.
bother you.
I will leave you something that's very exciting.
Oh,
A lot of
talk to me.
states that are talking about bringing cardiac procedures into the ASC space.
Yeah, I was told that. What kind of procedures
So there'll be
are they
PICs.
talking about?
There'll be PIC procedures. So the cool
What
thing,
is that? I don't know that.
um, so I mean, hold on. I'm gonna give you the exact terminology so I don't sound like a
Hmm.
goofball.
We're very exacting here.
Right?
Exactly.
Where did it
Don't
just
you
go?
come at me with something close. God no.
Right. So it's a PCI. So it is, let's see the exact terminology on here. So we're in the midst in Illinois of drafting the language that I got asked to be a part of the subcommittee for our licensing board.
Nice. How familiar were you with cardiac cases? Yeah. Okay. I mean,
I just in the inside the hospital system. I mean, because that's where you did them.
yeah. Well, I talked to a private equity physician who ran a big private equity in pain management, and he was telling me that the cases that they're targeting, ambulatory surgery centers, ortho,
Hmm.
spine, cardiac.
Yeah.
And I said, cardiac?
Yeah.
He basically said, where you been?
Yeah. Right. Yeah. It's a
Not in
percutaneous.
cardiac.
Yeah. Percutaneous coronary intervention is what they're looking at. So CMS has approved some procedures, and it's a hot topic. Moving on from being administrator, as you know now, I'm on the rep side as a vendor, not selling a product, which is great. So it's been kind of nice to kind of take a step back from clinical and just do it on a consulting aspect.
Mhm.
But it's been interesting to see all the different states kind of rally together now and be a part of like having these conversations and trying to put the language together. Because being a CON state, which people don't understand, is a certificate of need. You actually have to prove your need where you want to build a surgery center and then
Yeah.
apply for it and then get whatever. So they have like very, very harsh language inside all of their ambulatory surgery center treatments center types of stuff. So it's very exciting stuff that we'd be able to talk about probably in a couple months.